Hello, hello. Hello, sir. Hello.
Yes, sir.
Hello.
Yes, sir. Please tell me.
Can't hear anything, sir.
Yeah. Sir is still connecting. Just give a minute. He'll connect. Dr. Madhusudanan is just joining in a minute.
Am I audible to you now? Hello?
Yes,
Yes, sir.
sir.
You're audible. You're audible.
Am I audible?
Yes, sir. You're audible.
Yes, sir.
Am I audible?
Yes, sir. You're audible.
Okay. There's some problem initially. Okay. Just one more minute. Just find out. Am I audible now? No?
Yes, sir. You're audible. You're audible.
Okay. Thank you. Right. So good evening to all of you. As usual, I'll start with a fresh, short case first. Okay. This is a story of a 60-year-old man. This case is referred by Dr. Parameswaran. This patient was having left focal seizures for the last 10
slide
years.
is not visible, sir.
Please share the screen, sir.
Okay. Right. I forgot to do that. Just 1 minute. Are the slides seen now?
Yes, sir.
Yes, sir.
Okay.
We can see.
Okay. This is a story of a 60-year-old man. This case is referred by Dr. Parameswaran. This patient was having left focal seizures for the last 10 years, which was well under control with medication. In fact, he had some withdrawal seizures 5 years back, and he underwent brain imaging at that time. The imaging done showed right parasagittal tumor, for which he underwent surgery, and biopsy showed a low-grade astrocytoma, and he was given subsequently focal radiation done. Since the time of surgery, he noticed difficulty in walking with the dragging of the left lower limb. However, he noticed progressive worsening in walking, especially for the initiation of the gait for the last 1 year, more so for the last 3 months. The story is like that. He had a tumor in the right parasagittal area, producing focal seizures, which was not detected earlier. Only seizures was the initial complaint. When he stopped the medication, he had recurrence of seizures, and at that time, imaging showed a right parasagittal tumor, which had turned out to be astrocytoma. Following the surgery, he noticed my left hemiparesis, which has been remaining like that. However, he noticed progressive worsening in walking, especially for the initiation of gait for the last 1 year, more so for the last 3 months. This is the story. So, on examination, hymenal functions were normal, cranial nerves were normal, motor system mild spasticity to the left upper and lower limb, mainly for the left lower limb. Power was normal, deteriorated disc on the left side, left anther was like hemiparesis. Sensory system grossly normal. I will show the video. I am not showing the entire examination finding because it's a well-known person not to be shown the entire video. So I will show the gait of the abdomen to the patient. So this is the gait of the patient. And turn around and walk. See that he had left hemiparesis, but the main problem was the right lower limb. He cannot initiate the gait with the right lower limb, but bilaterally more on the right side. This is a turnaround. Once after starting walk, he could do relatively well. Again, Mandi macro attack. Around and come this side. Fast at either. So I'll show the video part once again. And turn around and walk. This is the difficulty he had mainly in turning and starting to walk. അങ്ങറ്റം വരെ പോയിട്ട് again വണ്ടി മാറ്റോട്ടാക്കിക്കുക. നടന്നോ around and come this side. So what is the likely diagnosis in this patient?
Parkinsonism, sir.
Parkinsonism, sir.
More likely looks like a Parkinsonism, correct? But I tell you, his upper face faces absolutely no mask-like faces. Spasticity was the left upper limb, no rigidity, no akinesia.
Sir, it looks like a spastic ataxic gait, mostly the spastic gait on the left side, and start initiation. That is a frontal lobe disorder like things. Gait initiation problem and turning problem. So initiation of the gait is at fault. And also he has got some amount of spasticity predominantly on the left side in comparison to that of the right side, which may be a sequelae of the operation, what he had actually. And he has developed this problem now.
Okay, but if you look carefully, his main disability was at the right lower limb when he started initiation problem.
Yeah, right lower limb. So there is definitely some involvement of the left side also. So this is parasagittal region that can involve the both sides in a similar fashion.
Okay. Right. Okay, let's see. Then, so what test you would like to do in this patient?
We will go for and repeat MRI.
Right. So MRI was done. This MRI I will show one by one from the lower cut upward. This is the flare sequence. This MRI, I'll come back. This is the uppermost cut. The operation was done on the right side. This is little more uppermost cut. Still uppermost cut. Okay, T2, we'll show the T2 sequences. Sagittal cut. I'll come show the, I'll show it. Just 1 minute, I'll finish. Your voice is breaking. That's you're not audible. This is the coronal T1. Okay. I couldn't hear you.
Sir, size of the ventricles. Sir, ventricular size. What is about just angles, Evans angle, sir?
No, there is some problem in the voice here. Somebody is open the both mobile and laptop together. If you operate two instruments together, this echo will come. I couldn't make out one.
Please close one. Please close one. Please close one.
Yeah, correct. Don't open two things together.
The size of the ventricles appears to be a bit enlarged in comparison with that of the cortical atrophy.
Okay, so what do you like to do?
Because of hydrocarbons, sir.
Okay,
Yes, sir.
okay.
NPH, I want to exclude NPH.
Okay, right. You want so some problem in the voice. I think your sound is got echo because you should not open two instruments simultaneously, like for example, mobile phone as well as laptop simultaneously, then this kind of noise will come.
We do a
Okay.
CSF tap and see, sir.
Yeah, what will you like to do?
CSF tap and observe the gate.
Okay. So this video was after the treatment. See, the initial difficulty was the right lower limb. It's much better after the treatment.
Yes, sir.
Definitely better. Now your sound has become better now. The echo has gone. Okay, what was treatment given?
CSF drainage, sir.
CSF drainage.
Yeah, look at the MRI once again. So this point I have clarified and went 2 weeks back. See, what we look for is the window sign here. This is the window sign. And the CSF lake. These are not atrophy. The CSF lake, the sulci will become prominent. And if you look at the parasite area, these areas are all crowded here. There is no sulci seen here. And there is no sulci, but one sulci is very prominent. And that is what is called the DESH. If you find DESH in an NPH, that's got a good prognosis. They will improve very well. So what the treatment was, CSF tap was done after 3 days. But that's a moral of the story there. So he had, in fact, the difficulty, one may think that it was recurrence of the tumor or to the operation risk, but what he had was a normal pressure hydrocephalus. Okay, this is what I do in my practice, because why I brought this case was that 2 weeks back, we had a discussion on NPH, what case of NPH, what is the discussion, how will you treat and all. This is not a uniform thing. This is what I do in my practice. And the I'll give justification later on. If the clinical picture favors NPH, where the gait abnormalities, it should be the predominant symptom. If demonstrates the predominant symptom, they do not improve very well. And neuroimaging shows ventricular dilatation, even if all the characteristics which are not there. I will do CSF tapping with a large bore needle for 3 consecutive days. and assess the response after each CSF tap. Even if the patient shows good response after the first CSF tap, I'll continue with all the 3 taps. The patient shows good response, I will note the shunt now. The idea of doing the CSF tap test is to predict the responsiveness for a shunt. But I have seen, why I do not do the shunt, because I have seen that even after 1 tap or 3 tapping for 3 consecutive days, patients remain perfectly well for many months. As suppose normal physiology, the CSF should reaccumulate within hours. But practically, this is what we are seeing. I have seen patients remaining asymptomatic for many months or even under 2 years after the CSF tap in the NPH patient. They do not come back in worsening again. Now, if the patient did improve only partially after the CSF tap, still I will differ from shunt surgery for some time, because I have seen some of them improving after weeks. See, if you do a CSF tap, you do not find a rapid improvement. Some of them do improve later on after 2 weeks. The improvement is satisfactory, even though not entirely normal. I will not again send it for a shunt. The patient has improved and again worsened. I will discuss with the patient about 2 options, shunt surgery or repeat CSF tapping. To my surprise, many of them offer CSF tap, repeat CSF tapping, because they felt very well for a period of time rather than submitting them for surgery. What if the patient did not improve at all with the CSF tap and the clinical picture is very typical of NPH? Many will not do shunt surgery. Why this CSF tap is designed to decide whether they will improve with surgery or not. Okay. But what I do is that I will discuss the patient and coax them to do the shunt surgery. If the diagnosis NPH is certain, if you find a typical gait abnormality, incontinence, and ventricular dilatation, CSF type is negative, still I will coax them for a surgery. Because I have seen patients respond to shunt surgery weeks after shunt who did not show any response after CSF type. I will show 2 other cases. This is in Malayalam, you may not understand. This patient had done CSF type 1 year back for a walking difficulty. He has come now after 1 year. He's speaking in Malayalam. I think you can skip that. Whatever he is telling that. Now he has come back with walking difficulty. He said no medication. Worsening for? He said after 9 months he has got some difficulty. Even now he's walking relatively well, but he thinks it's slightly slow than before. That used to come back to me again. Now this lady was admitted earlier about 8 months back, with total inability to walk and not able to sit in the bed. When you make him sit up, she'll tend to fall backward. And your MRI showed typical of NPH. So I had no doubt, I promised that you will definitely improve with your CSF tap, but she did not improve with CSF tap at all. This I will stop her. She did not improve with the CSF tap at all. Then the surgeon did, when I called the surgeon to shunt surgery, he was not willing to do surgery. He said the CSF did not produce any improvement, why should I surgery? So shunt was done, again no improvement at all. Absolutely no improvement. So 2-3 weeks we were all in dismay whether the shunt was not working or not. He titrated that thing, this thing, that what do you call the adjustment, we were all done. After 2 months, this is what the patient had. He improved remarkably. The patient was not able to sit in the bed, able to walk normally. She came for follow-up 1 week back. She could walk very free without any support. She was walking normally. You could get on with the walking normal. So what I'm trying to say that some of the people who do not respond to CSF tap, is typical, go ahead and with surgery, they do improve after some time. So this is the message. This is from my practical experience. So any questions?
What is the explanation for this delayed improvement?
We do not know actually. Probably what I feel that there is not only the CSF drainage matters, some other material or neurotransmitter which has been causing the problem is also removed from the CSF. One explanation. Some amyloid there is one what is explanation given in the textbook. What I personally feeling that when you do a CSF tap with a large bore needle, the CSF continue to leak for some more time. So that may be one reason why they got delayed improvement. I do not think that both explanations are satisfactory, but practically I have seen patient improving. See, the first person, he said 9 months he was all right. Okay, any questions?
Sir, how much CSF actually you tap at a single tap? 30 ml?
No, 40 ml, 40 cc at a time for 3 consecutive days.
Thank you, sir.
In the first case, is the NPH related to the tumor surgery in any way?
Very unlikely because the ventricle is dilated bilaterally. More dilatation obviously will be on the tumor site. But you see, his weakness was the kinesia was more on the right lower limb. The surgery was done on the right side.
Sir, how many cases did you see this delayed response, sir? Like, because many
Um,
times sometimes we have done CSF tap and they did not improve and we send them without any suggestion for surgery. Now, how to
Yeah.
counsel them? Because how much can we guarantee that definitely it is going to improve, or how to
Yeah.
convince the surgeon and the patient?
If suppose I do a CSF tap, okay, 3 times, it did not improve much. 2-3 weeks later, to 1 month, 1-2 months later, you can reassess the patient. The patient does not improve again, then you have to submit him for. I will submit him for surgery.
Sir, my doubt is like how many the percentage of cases, how many that improve in the delayed time, in the delayed phase.
How many people will improve?
Yes, sir.
That
Like, can we tell that all the patients can with short diagnosis of
Most-
NPH radiologically and
No.
clinically going to improve?
No, most of them do improve after the single tap or second, third tap. They improve. In the hospital, usually they improve and walk off. And they remain all right for some time. But what I'm trying to say, some of them who do not show an improvement immediately after the CSF tap after 3 days, they can still improve after a period of time, 2 to 3 weeks time. You can wait for 3 weeks time.
So
I
you're
call
telling
them.
that we can look them after the doing CSF tap now. We can review them after 1 month once again.
Yeah, exactly.
Okay, sir, understood.
Right.
Sir, do you give acetazolamide, sir?
No. I initially I used to give in my early days of practice. I found absolutely no use with Diamox. So I never give a Diamox in this patient.
So lumbar tap is not an absolute diagnostic test.
No, there are many other diagnostic tests for NPH. None of them are foolproof. All they have got a false positivity and false negativity. The only relatively good test to diagnose NPH is the response to CSF tap. All other radiological tests, everything, and the other radiological finding which relatively helpful diagnosing is the DESH. This also I discussed the last time. All other CSF flow studies, your PET studies, everything has got pitfalls. They do not really distinguish between, whether they respond or not.
Sir, what is the improvement we see clinically? How do we define that, sir?
If you're able to walk normally, incontinence disappears, the gait becomes remarkably well. This lady came 2 weeks back. She was walking normally just like any other normal person. Absolutely normal. I thought I didn't take the video, I should have taken the video. So it'll take some time for the improvement to occur, but the most criteria is the normal walking.
Dementia does not improve much.
They do not improve. Dementia does not improve. I've seen some mild improvement in some, but not many of them do not improve.
Some people,
Incontinence.
if there is partial improvement also, they ask them to go for shunt. That's why I asked how much is the improvement, should we define it?
Okay, to decide on shunt surgery, correct? That's
Yes.
I don't know. That I don't know how to predict that thing. Suppose somebody has shown a partial improvement, and if it's not satisfactory improvement is not there, will the shunt produce another improvement or not? We cannot predict.
Okay, sir.
Sir, which patients you will not subject to surgery?
If if he has got a significant cortical atrophy, if the dementia is the predominant symptom, then they do not, and you saw if ventricular dilatation is there, then I do not submit them for shunt surgery or CSF tap. They do not improve. If the dementia is the prominent one, and you find a ventricular dilatation, they do not improve.
Thank you, sir.
Sir, do you stop clopidogrel before this tapping, sir?
No. For CSF tap, need not stop aspirin, need not stop clopidogrel, nothing. Even anticoagulation also, it need not stop.
Sir, I think there is one objective method of measuring the improvement, that is the 10 meter gait test. That is a pre-tap assessment of 10 meter gait time as well as post-tap assessment. And if there is 20% improvement, that is taken as a significant. And another is also the cognitive test. There is improvement of score of more than 10%. That may be an indicator. That is an objective.
Yeah, there is some object that studies with me, but I'll tell you this thing. Suppose the patient does not improve immediately. After this, you do this every day, you assess the gait and the 10-minute test. Still, they can improve after some time. That's what I'm trying to say. Still, they can improve.
No, I am not telling about the 10 meter. Not after 10 minutes. Pre-test as well and post-test.
Yeah. That's what I said. According to because ideally, after CSF tap, within 10 or 15 minutes, you have to do the response. But that's what the conventional take. But what I'm trying to say, even that response may not be there. Logically, scientifically, what I said is correct. Because CSF will reform within hours. But these people do remain responded for many days after that. That is what Dr. Mann was asking, what is the explanation for that delayed response? We do not know. Logically, CSF is reformed immediately, within hours. According to the rate of CSF production, if you take, they say within hours, it will be reformed. But you can see the improvement after 3 days, and many weeks later, they improve. That is an enigma in this patient, in these kind of patients. For example, this particular lady, shunt surgery was done. Okay. For 3-4 weeks, she had no improvement with shunt surgery. No improvement. 2-3 months later, she's gradually improved to this level. Even after shunt surgery, she did not improve. But over the time, she improved.
Sir, if the patient shows improvement after CSF tap, will we do the surgery immediately or wait again for the worsening?
No, that's the thing. Suppose the patient does improve remarkably well, not absolutely. If he is satisfied with improvement, we did not do the surgery. No, suppose if patient improved, then they go home. Again, come back with the walking difficulty. Then I give them 2 options. To either go for surgery for the permanent relief or do you repeat CSF tap. Many of them offer repeat CSF tap. And all the 3 patients, they wanted CSF tap rather than a surgery. The improvement is only very minimal, then definitely ask for the surgery. The first patient, no, this particular patient, he now 1 year back had the CSF tap. He remained 9 months, he was all right. Now he has come with mild worsening. Then he came only one thing, not for surgery. He said, yeah, I want tap one more to be done. So I did 1 more tap and he went back again. So that's so. Okay, shall I go to the next case?
Yes, sir.
This is a story of a 60-year-old lady. She came with a history of dizziness and imbalance while walking for the last 2 years. No other complaint. This is the patient. He had got a downbeat nystagmus. I don't know whether they were able to make it or not. I'll show the other, some of the part of the video, it's very clear. That's got a downbeat nystagmus. Ocular movements are all normal. Convergence was normal. And you can see the downbeat nystagmus very clearly. See the downbeat nystagmus? Mainly looking down and out, it has become prominent. And this is more prominent when the patient lies down and less become on sitting up. Sitting up also it is there, but more on lying down. Again, you can make out the downbeat nystagmus there. And this is the gait of the patient. This patient I saw in my house. Has got a gait ataxia was there. Turning, she's ataxic. Even tandem walking was defective. So she had downbeat nystagmus, which is more when it's lying, and gait ataxia. So she came with an MRI which was taken 1 year back. That is 1 year after the onset of the illness. Total duration is 2 years by the time she came to me initially. Then since it was not, this is the MRI which was brought by the patient that time. That is 1 year after the onset of her illness. The MRI was relatively normal. Gross abnormality you could make out. Cerebellum was also normal. There is no atrophy of the cerebellum. This is a T2 flare diffusion. So she was asked to come for admission after when I saw him. Then she did not turn up since she contracted COVID infection and came back after 1 month after the COVID. And then re-examined after 1 month. That's when I got her admitted in the hospital, re-examined. This is the proper examination. Has got a downbeat nystagmus, you can make out. The rest of the tailors were normal. Tone power was normal in upper and lower limb. No mild incoordination of the left upper limb. Lower limb power was normal. The reflexes are also normal. Slight to the briscus side. But tone power was normal. Plantar flexor. Sensations are all normal. She said correctly. Lesion test was mild incoordinations on the lower limb. Then this is the gait to the patient. Even with eyes open, she was ataxic, tendency to say to both sides. Shows the main affection was the procranoidal lobe, downbeat nystagmus, as well as a main predominant gait ataxia with less of limb ataxia. Okay. So on examination, don't be nystagmus is more in the head hanging position. First of the canals are normal. Motor tone power normal in upper and lower limb. Details slightly brisk, plantar flexor, sense system normal. Mild finger nose incoordination, Hilton positivity. So what is the diagnosis I would like to do in this patient?
Late onset cerebral ataxia.
Okay, this 2 years
Could be
duration.
the-
Yeah. Right. Late onset. Some CA, no?
ACM type 1.
Okay, type 1, agreed. But non-B nystagmus classic type 6. And later onset also is more favoring type 6. Okay,
But
right.
evaluate for treatable cause, no, sir? Autoimmune versus paraneoplastic.
Okay, right. So what do you want me to do?
Repeat MRI and
This is repeat MRI. Okay. So these are the possibilities one should keep treated. ACM, subacute cerebral paraneoplastic, autoimmune, anti-GAD, celiac disease, Wernicke's. Okay. So repeat MRI was done. First, I wanted to rule out AC malformation, Arnold series malformation. There is no ACM in this patient. Not much of a cerebellar atrophy also. No ACM. So it a proper MRI for the other any abnormality in the cerebellum. This is a T2. Again, normal, not no atrophy at all. This is the flyer sequence. At all. So what else you want to do now?
CSF.
CSF what?
Autoimmune paraneoplastic.
Autoimmune. See, in this kind of patients, you should do always paraneoplastic workup. Why? Because, see, 2 years duration, it's slightly odd, but still can occur. But no cerebellar atrophy. If it is spinocerebellar ataxia-like condition, SCA, you expect some atrophy because it's a degenerative disease. But here there is no degeneration. There's no atrophy even after 2 years. So we did a paraneoplastic workup. All paraneoplastic antibodies negative. Whatever, ANNA, PCA, paraneoplastic cerebellar antibody negative, AGNA, CRMB, anti-amphibicinema antibody negative. So what do you want now?
Anti-Kelch level antibody.
Pardon?
Anti-Kelch level antibody which can come with this kind of ataxic presentation.
Right, anti-GAD, correct. So anti-GAD was done. That's also normal. Now what do you want?
PET scan.
Okay, PET scan. So whole body PET was done. Shows intense FDG uptake in the left lobe of heterogeneous enhancing thyroid gland. Then, so that is PET enhancement. And ultrasound thyroid was done, showed a nodule in the left upper pole, and surgery was done. And it turned out to be a papillary carcinoma of the thyroid. So surgery was done, and this report. She followed up after 6 months after surgery. No improvement in the downward dysfunction. And that all the findings remain the same. So the fingernails incarnation. She has not worsened. She has not improved either.
Sir, does she have telangiectasia, sir?
Not telangiectasia, it's only dilated conjunctivitis. That's okay. Then she followed up. She came for follow-up 3 years later, in February 2025. Again, the same findings. I got a downwind nystagmus. Same things have been more.
ശരി ഇനി കണ്ണ് തുറന്നേ സ്പീഡ് നടന്നു വാ നടന്നോ സ്പീഡ് നടക്ക് തിരിഞ്ഞു നടന്നേ താഴെ നോക്കി സ്പീഡ് നടന്നോ
So what is the diagnosis now? Same. It's a paraneoplastic cerebellar degeneration. See, in PCD patients or paraneoplastic syndrome do not improve even after removal of the tumor. I've seen another patient with PCD, again, did not improve at all with surgery. She had a carcinoma, breast or something like that. She also did not improve. Unlike other autoimmune encephalitis, where when you remove the antibody or treat with immunosuppressant, they improve. But those with paraneoplastic syndrome, they do not improve. If at all you want to treat or to give endoxan for this patient, they not improve with rituximab or steroid. Because that's a cell-mediated response which is occurring in paraneoplastic, unlike antibody-mediated. So this...
But she has not deteriorated.
Not deteriorated. That's the only thing. Even after she came for 3 years after asking the patient, she has not deteriorated at all. If she's complaining, her main complaint was his eye problem.
Sir, do you prefer anti-neoplastic panel or FDG PET or both, sir, together?
That's a very difficult question for me. If the patient can afford, I will always go for a FDG PET. Because that we can pinpoint where the malignancy is. So because paraneoplastic antibody may be negative, as in this case. And moreover, we are every day newer and newer antibodies are coming. So which antibody is there we can test? We do not. But if the FDG PET is there, we know there is a malignancy underneath.
Okay, sir. Thank you.
If it is negative, you have to repeat FDG PET after some time. I will show another case. Okay. This is case given to me by Dr. Roy Thomas. A 50-year-old woman present with history of seeing images moving up and down as if his filming is moving up. That's exactly what he was told. This was there for the last 1 month only. When she was looking at me, she saw my head moving up and down. The symptom was present while at rest as well as while walking. It is present with binocular and monocular vision. It is more when the patient looked at a distant object than near. No headache, no vertigo, or any other kind of symptoms. For the same duration, she also noticed tremulous movement of the left hand. It was more while she was holding an object. There was no walking difficulty. This is the history. I think I will skip the history. She is moving up.
എൻ്റെ തല മുകളോട് താഴോട്ട് ആക്കുന്നുണ്ട് ഓക്കെ മനസ്സിലായി ഇപ്പോഴാണോ ചാടിക്കൽ പറയുന്നത് ചുമ്മാ ഇത് നേരെ നോക്കിക്കൊണ്ടിരിക്കുമ്പോഴാണ് ഇതിനെ കാണുന്നത് ഇത് നടക്കുമ്പോഴൊക്കെയാണ്
So it is present, oscillopsia is present while walking as well as while sitting. That means if it's only present while walking, that is due to the defective vestibulocular response. Here it is present all the time. That means some ocular movement abnormalities responsible for that. So examine the patient. This is just a nystagmus. You can look at the nystagmus now. So could equal velocity and up and down. It is not the nystagmus per se. It is not a classical jet nystagmus per se, but a nystagmus with equal velocity up and down. There is no fast component, only slow component is there. It was looking in all directions. Now it becomes more prominent, looking to one side.
പെരലിൽ തന്നെ നോക്കേ, കണ്ടല്ലോ അമ്മ, ഇനി നോക്കേ, ഇവിടെ നോക്കേ, അങ്ങനെ ഒരു മിനിറ്റ്, അത് തന്നെ.
You can make out the particular nystagmus.
ആ ഭിത്തിയിലോട്ട് നോക്ക്, മുകളിൽ എവിടെയെങ്കിലും നോക്ക്, ഇനി മുകളിലോട്ട് നോക്കുമ്പോൾ താഴെ മുറുക്കി അടച്ചേ, കണ്ണ് തുറന്നേ, ഈ നാക്ക് നീട്ട്.
Rest of the cases are all normal.
മാസ്ക് ഇട്ടമ്മ, മാസ്ക് ഇട്ട്
Power is normal. There is finger nose incontinence in the left upper limb, not on the right upper limb. Incontinence is in the left side. Right, if at all, very minimal, if at all, is present. Lower limb tone power normal. The inclination also is slightly worse on the left side, normal on the right side. That is on the left side. The reflex is bilaterally brisk. Plantar was subgoing bilaterally. Sensations were all normal. Joint position also normal. Even with eyes open, she's ataxic, tends to fall to both sides. More towards left side. He walks with a broad gaze and tandem walking was defective. Now, before that, I'll tell you one more point. See, osteopsia is more often seen with pendular nystagmus and not with the jerk nystagmus. Sometimes downbeat nystagmus can also produce osteopsia, but ordinarily we don't. So suppose classical case of nystagmus and all are beat out. They don't complain of any osteopsia. But if it's a pendular nystagmus, they invariably complain of osteopsia. The reason is because there is visual suppression during the saccadic movement. For an ordinary jerk nystagmus, there is a pathological slow component and a fast component, which is the corrective component. During saccadic component, there is visual suppression. That is why you don't get classically osteopsia in jerk nystagmus. If it's but during the slow component, sometimes you can have osteopsia movement of the osteopsia. But the up and down movement like that, if somebody is complaining that, it is more likely to be pendular. Because an up and down slow movement is okay, because both components should be slow. The classical jerk nystagmus, the fast component does not produce any perception of the movement. Okay, so what is this type of nystagmus the patient has? It's got a binocular, vertical, pendular nystagmus in all directions. It was more when the patient looked at a distant object. It did not change with the gaze direction. Extraocular movements are normal. Rest of the canal is normal. Motor examination, tone power normal in both upper and lower limb. Radial bilaterally brisk. Plantar going bilaterally. left-sided finger nose incoordination, then sensory system normal, gait broad-based, slow gait. I think skipping. So this is acquired meningitis diagnosis. Okay. So what is the diagnosis in this patient? Localization, likely diagnosis.
Brainstem
So can we see the
Pardon?
can we see the nystagmus once more, sir?
Yeah, sure. I'll show the nystagmus. In fact, I should have taken a close-up view. I'll show the nystagmus. The better one I will show you now. And up and down. Here also no. Okay, that's it. Equal velocity movement up and down. It is present in all directions. You can down also you can make it out now. You can make out there. Okay.
It's an acquired pendular nystagmus.
It's acquired pendular nystagmus. So
Usually
there is a class.
Gillen-Muller triangulation.
Yeah, classically described in Gillen-Muller triangle lesions. Very classical one is the one which you find palatal nystagmus and oculomotor nystagmus, the ocular myoclonus, which you see in so-called ocular myoclonus. That's all due to the acquired lesion of the Gillen-Muller triangle. And there's other causes can be due to visual deprivation can produce pendular nystagmus. Even if it is acquired, can produce that thing. So this, I think this is classical set. What are the causes? Can be disorders of central multiple sclerosis is another condition where there is involvement of the central tegmental tract can produce acquired nystagmus. Then these are other rare conditions like Cockayne syndrome, Bellishmell's bucket disease, induced, and visual loss is an important cause. And lastly, the ocular paralytic trauma, that is a classical seen with the Gillen-Muller triangle. Okay. Right. Other causes include acute brainstem stroke, Sandage disease, cerebral Whipple's disease, hypoxic encephalopathy, neurosarcoidosis, serotonin syndrome, diphenylredundant toxicity. These are all non-causes. So what do you think is the likely cause in our patient?
Stroke, sir.
It's not an acute one. It's over a period of 2 to 3 weeks time. And does it fit in with the vascular territory? Yeah, good theoretically, because left side ataxia is more downbeat nystagmus. And sorry, but then it's bipyramidal signs possible.
MS.
So what you are thinking of a structural, always when there's asymmetrical involvement, say left upper and lower limb, see clearly left side involvement is more than the right one. When you get a symmetrical involvement, think of some kind of a neurometabolic or a neurodegenerative thing, conditions like that. Okay, but you think of it more likely to be structural when there is asymmetry, like a vascular malformation or like cavernoma or demyelinated MS or like a tumor or infarct, whatever it is. So what investigation? So these are the things I kept in mind: brainstem mass lesion, granuloma, brainstem demyelination, Clipper syndrome, and paraneoplastic autoimmune lesions are less likely because of asymmetry is there. But it can be asymmetrical also, paraneoplastic syndrome. I have seen another case which is clearly asymmetrical. So what investigation you need? MRI, no?
Yes,
I
sir.
may not what. Yeah, okay. So this is the MRI. Patient came with this MRI. There is no lesion seen in the MRI brought by the patient. This is the diffusion. Cervical cord was also done normal. So what do you want now? In fact, I really expected a lesion in the brainstem.
Contrast MRI.
But I was not satisfied with the MRI brought by the patient. So I repeat the MRI with 3D flyer study and visual contrast study. Thin cut was taken. This is the repeat MRI. Again, 3D flyer studies, no lesion seen. So what do you want now?
Paraneoplastic panel.
Okay. CSF and paraneoplastic antibody was done. You showed anti-SIG4 antibody was positive. Unfortunately, the routine paraneoplastic, this antibody is not done, but make sure that this antibody has to be done. So this, and is in patients with neurological symptoms of unknown cause, detection of SIG4 antibody predicts a neoplasm, usually a small cell carcinoma, and suggests that neurological disorder is paraneoplastic. So these antibodies, which we usually do not do, but you have to do that because this is a real marker for a paraneoplastic syndrome. Detection of SIG4 antibodies often associated with anti-Hu or CRNB5 antibodies are more likely to develop cerebellar dysfunction than those with concurrent immunities. This is another case report of article, isolated SIG4 antibodies in paraneoplastic cerebellar syndrome with an underlying ovarian tumor. So what else you want now?
PET scan.
FDG PET, no? But the CT test was done that showed a well-defined enhancing irregular lesion with speculations in the anterior segment of the right upper lobe abutting the minor fissure of the thickening. She underwent a biopsy from that sample and that turned out to be, I think, squamous cell carcinoma or something attended because I forgot whether it's squamous cell or adenoma carcinoma. Anyway, carcinoma was there. So this is a SIG4 antibody positive paraneoplastic brainstem encephalitis, where the MRI is entirely now.
Sir, why
Again,
don't they do ZIG4 in regularly?
I don't know. Maybe I don't know why they do it like that. Nowadays started asking specifically paraneoplastic syndrome, including SIG4. Yes.
No, now they're doing, sir. Even without asking, they are doing SIG4. I think in Amrita they are doing, I think.
Amrita, right. Amrita, they are doing most of the antibodies. Okay, so that's the story of the two cases of paraneoplastic syndrome, one with a downbeat nystagmus, one with acquired pendylar nystagmus. Both had a normal MRI in the brain. So any subacute cerebellar syndrome, even with a long duration as long as 2 years as shown before, you have to investigate for a paraneoplastic syndrome. All the time, the clue is that there is no atrophy in the cerebellum of the brainstem. Paraneoplastic syndrome can produce atrophy, but the different thing. If atrophy is there, then the other CS symptoms also comes into picture. When there is no atrophy with a long duration, always think that there is something, other treatment cost may be there. Treatable cost may be there. Okay, shall we stop or go for one more case? Any questions?
Sir, subacute presentation, we will tell only up to 8 weeks, sir. Here, the patient had a symptom of around 2 years, and how do we attribute this to a subacute presentation, sir?
Yeah, that's the thing. Paraneoplastic syndrome can antedate can detect some malignancy by many years, even up to 5 years they have described. There it's not a subacute, it's a chronic one. So this subacute, acute are all arbitrary. The duration is quite arbitrary. It's not 8 weeks or 2 months or 3 months. The more important is that even after long years, there is no atrophy of the brain, or cerebellum. That is the clue you have to take.
Okay, sir. So, but paraneoplastic panel, usually we do it with autoimmune panel because paraneoplastic are autoimmune, sir, but not all autoimmune are paraneoplastic, sir. So, we tend to do both in our hospital, sir.
Yeah, that is ideal. That is ideal. For example, anti-GAD antibody is it's not, it can be paraneoplastic and non-paraneoplastic also. And anti-GAD positive and cerebral animal, they respond very well to treatment, unlike other paraneoplastic syndromes.
Okay.
So paraneoplastic are usually anti-neuronal and they will not respond to treatment.
Correct. Exactly.
And the other antibodies are surface antibodies.
Yeah. The other thing is surface antibody. This is a nuclear antibody, a neuronal nuclear antibody. That is why they did not enter into that thing and produce improvement. And most of them are cell mediated.
So the last case, the nystagmus increased on lying down, sir. What is the relevance of lying down, sir?
Yeah. This is another point I would make you. I want to tell you. In the case of downbeat as well as upbeat nystagmus, always do the position change, especially downbeat nystagmus. In SCA6, classically the nystagmus aggravates by lying down. Similarly, ACM, unknown cherry malformation, because the compression by the ACM is also more on extending the neck. There again, the nystagmus can be aggravated. And so this and also certain metabolic conditions, I forgot about it. So in the case of something, there also it will aggravate with position change in the case of downbeat nystagmus.
Thank you, sir.
Shall I stop for one more case?
One more case, sir.
Okay. Short case I will give you. Okay. It's not that short. Anyway, let me see how many minutes are there. Okay, 15 minutes I can say. This is a story of a 53-year-old male. His complaint started 5 years back as difficulty in holding objects in the right hand and difficulty in elevating the right arm for the last 3 years. Unable to ring close with the right hand and difficulty in writing for 6 months. So 5 years duration of progressive weakness of the right hand, first at the distally and then elevating the right upper limb. See, even though patient has got weakness, they do not come to weakness of the left hand because they are not using the left hand. This also you have to keep in mind. So let us see the examination of this patient. His cranes are
ഇവിടെ മോളില് വാ തുറന്ന് ആന്ന് പറഞ്ഞ് ആ മതി രണ്ട് മുറുക്കി അടച്ചേ മതി ഇങ്ങോട്ട് തള്ളിക്കേ.
sternum muscles are normal. Now you have the wasting of the small muscles, especially the thenar muscles, is wasted. Bilaterally more on the left side. Tone was normal. And both deltoid were weak. Triceps also weak, but more weaknesses in the deltoid. Triceps good power, but weak on one side. Wrist extension is normal on the right side, weak on the left side. So left upper limb is more weak, but the complaint was on the right side. Finger extension is weak bilaterally. See, the wrist flexion was normal bilaterally. Look at the finger flexion. Gross testing, it was normal. But flexor pollicis longus was weak on the left side. On the right side, it is normal. Start examining flexor digital profundus of each finger. All were normal on the right side. Now on the left side, flexor pollicis longus is weak. So also weakness of the FDP of the index finger was weak. But the middle and the fingers was mild weakness. Middle finger, ring finger and little finger was normal. That is weak. See, if you the pointing index sign, see this is weak on the right side. Thumb was weak, index finger was weak, middle finger was mildly weak. Finger abduction was weak bilaterally. Abductor extensor pollicis longus was weak bilaterally. Introduction was weak, but not as weak as other things. Look at the extensor. See, the little finger is more markedly weak. That is, see, it's not even against gravity, you cannot lift up the little finger, little extensor. Something like a myelopathic hand. Common sign was positive bilaterally. Palmar introduction is also weak.
That is weak.
Flexor pollicis brevis was weak.
That is called.
This opponent side is weak. That's an 87 is positive bilaterally. Scapular muscles were normal. That is because the weak deltoid. External rotation was weak on the left side. Right side is bilaterally weak, but internal rotation was normal. The lower limb don't power normal.
നേരെ പൊക്കിക്കേ മതി ഇത് പൊക്കിക്കേ മതി വിട്ടോ തള്ളു
Knee extension normal.
ഇതും തള്ളി മാറ്റും തള്ളു 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 കീഴോട്ടാക്കാൻ സമ്മതിക്കല്ലേ
Normal power the feet.
ഇതും പിടിച്ച മുകളിലോട്ട്
THL was normal.
ആ ഇനി ചവിട്ട് എൻ്റെ കയ്യേലെ ആഞ്ഞ് ചവിട്ട് ചവിട്ട് മതി കാലാപിക്കാൻ സമ്മതിക്കല്ലേ
Abduction adduction was also normal.
വിട്ടോ
Reflexes just elicitable in both upper limb, just 1 plus flicker of movement.
ഒന്നും ചെയ്യരുത്.
This was also just elicitable. Finger pressure absent. Up down reflex was sluggish, elicitable but much less. Knee jerks were brisk, more brisk on the left side. Ankle jerks were normal. Indefinite. Sensations are all normal. That is normal.
അറിയാലോ ഇതും തമ്മിലോ ഇതും ഇതൊക്കെ ഒരേപോലെയാണോ ഇങ്ങനെ കുത്തി വരുമ്പം എല്ലാം ഒരേപോലെ അറിയാമല്ലോ ഒരേപോലെയാണോ ഒരേപോലെയാണോ ഇതൊക്കെ ഒരേപോലെ അല്ലേ ശരി ഒരു
വൈബ്രേഷൻ is normal.
ഇപ്പോൾ ഉണ്ടോ ഇപ്പോഴോ 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 ഉണ്ട് ഇപ്പോഴേ
JPS sensation is also normal.
ഈ വരലി പറയണേ ഇപ്പോഴോ ഇപ്പോഴേ ഇപ്പോഴേ ഇപ്പോഴോ ഇപ്പോഴേ 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 ഇപ്പോഴേ
He said correctly.
ഇപ്പോഴേ ഇപ്പോഴേ ഇപ്പോഴേ
Gait was also no. On standing, he could not stand on heel on the right side. Mild weakness was on the right side, but plantar flexion was normal. So tail nerves normal, tone normal in upper and lower limb, wasting of both inner muscles, mild wasting of the introduction on both sides. Power of the upper limb. This you have to keep close attention to this and power of the upper limb. Weakness of both deltoid, left more than the right. Biceps 4 to 4 plus bilaterally. Triceps almost normal bilaterally. Wrist section and flexion was normal in the right side. Wrist section is weak on the left side. Finger extension bilaterally weak, but maximum weakness or extension of the right little finger. There is a finger drop of the right little finger. Other fingers about 3. That finger was 0. Wrist extension. Flexor pollicis is weak on the left side, normal on the right side. Flexor digital long as the left index finger is weak. Other long finger flexors are normal on the left. So also all the finger flexors on the right hand were normal. For the lower limbs normal. DTR both upper limb all just elicitable. Knee jerk brisk, left more than the right. Ankle jerk just 1 plus. Abdominal plus like this. Plantar positive sensory system normal. So what is the likely site of lesion in this patient?
Central cord, sir, or bibrachial MND, the other differential diagnosis, sir.
Bibrachial MND. Okay. What else was telling? I did not hear that.
Central cord syndrome, sir.
Central cord syndrome. But he had no sensory in the upper limb, no temperature loss or pain loss in this patient. I agree with you. There is weakness of the upper limb muscles and reflexia, brisk from the lower limb. You have to keep the possibility of a central cord. That's a good thought you have kept in mind. But only thing is sensory is absent.
This is predominantly lower motor neuron involvement and not confining to any roots, sir. Mostly nerves, maybe mononeuritis multiplex, but the duration is pretty long, sir.
2 years.
No
sensory in this patient.
Motor MMCB, sir. Motor neuropathy with condition block. That can be long duration.
Okay, correct. Very good.
Patchy involvement, element and human findings.
Okay, what did MND? Okay.
MNDLS.
MNDLS, okay. Right. But there's no spasticity in the upper limb. Okay, that may not be there. Right. Any other thought? No, what is a strike? Yeah, please. Pardon? Hirayama, but all the muscles are affected, not the upper limb. Almost all muscles are affected. Not in the distribution of a classical Hirayama syndrome.
Sir, there is a fascicular selectivity, sir. Since only the little finger there is a drop, but the other fingers are.
Very good. That is usually seen in a myelopathic hand, correct? Can be seen cortical artery. But I tell you, over years, I'll tell you, this can occur in any lesions. Even neuropathy also can occur because the fascicular vulnerability, especially MMCB and conditions like that, it does not involve the entire nerve. Only part of the nerve can be affected. That can put in this kind of a finger drop. But what you said is correct. This kind of phenomenon is classically described what is called the myelopathic hand. The little finger maximum affected, extension is affected, then the ring finger, and the abduction adduction is maximally affected, those two middle two fingers. That is a classical description of the myelopathic hand. But there the reflexes are usually brisk because that weakness is a pyramidal weakness. Here the reflex is decreased. Can you tell me one important finding in this patient which makes you think away from a motor neuron disease or a central cord syndrome?
Finger drop, sir.
Finger drop is, as it can be patchy involvement in motor neuron disease.
Absence of fasciculation.
No, okay, that's not anyway, it's element. But I'll tell you this particular finding. I'll show you this one.
Anything for Hansen, sir?
No, not Hansen. This I'll show you this finding. This is him. On the left hand, the weakness was involving the flexor pollicis longus and the index finger, middle finger, not in the ring. Oh, see that one. That is weak. That is weak, but middle finger is mildly weak. But ring finger, little finger is normal. What does it favor? The distribution of
Median.
and see this one. If you find a pattern like this, exactly the distribution I did it is not the distribution of the median now. The other fingers are not affected. It's affected. Okay. In fact, that shows that the nerves are affected in multiple areas. Something like a mononeuritis multiplex, as one doctor was mentioning it correctly. Something like involving multiple. That's the important clue to make you suspect that it is not fitting with an anticonceptual disease or fitting with a central cord syndrome. Otherwise, seeing brisk reflexes, one should naturally think that point. And this is the one point you have to keep in mind. So What is usually what you do? MRI was done. MRI what? Okay. The cervical cord is normal. So what else you need? NCS, no? Okay. This is NCS finding. Amplitude decrease in the both peroneal. See, lower limb clinically under, but right peroneal weakness was there. Dorsiflexion was weak on standing. That's also another important point to tell you that multiple nerves are affected. Even though weakness in left upper limb is more affected, right foot has got a foot drop. Only on making him on standing on walking on heel. Both peroneals are affected. The velocity is here, this may not be abnormal. The water circle on the right side may be normal. Because amplitude is low, this can be taken as normal. But here it is really abnormal, these two velocities, 30 millimeters, because he has got a normal amplitude. Okay, if the amplitude is less than 50%, if you take only abnormal, if less than 31 or 30. But the lower limit should be less than 28 to call it really demyelinating. But a decreased velocity 30 with the normal amplitude always is suggestive of a demyelinating disease. Again, look at the left median, no response at all. That is fitting with that anti-interstitial nerve. Then ulnar nerve. Then an interstitial median nerve. Sorry. Then left ulnar nerve is also affected. Left radial is affected. And the velocity is also decreased. But this velocity does not necessarily mean it is demyelinating because it should be less than 31 to call it a subnormal. Okay, up to now, what do you think? It can be axonal degeneration or a demyelinating, more likely axon, correct? Because amplitude is low, but the one direction is not that much decreased. This latency is also not affected. Now, sensory potential is normal. Now look at the F wave now. What does it tell you? It's typical of demyelinating polyneuropathy. See, the right median potential here was EMF amplitude is normal, but it is the FAV is inelicitable. All of the nerves also affect, all are inelicitable or causally prolonged. Even the tibial potential was normal. Tibial distal latency was normal. Conduction velocity was normal, but FAV latency is prolonged. So what does it tell you? There's a proximal demyelinating lesion. Okay. Did you understand what I'm trying to say? See, if you take these values, see, these values, this may be decreased amplitude is there. This decreased amplitude can produce a decrease in the conduction velocity to a certain extent. Only it is grossly decreased, it has got a significance. Here also, if you take this amplitude is less than 50%, but if the less than 50% means that this amplitude should be less than 31 or 28 to call it really abnormal. Because some degree of conduction slowing can occur because in axonopathy also, because the selectively more large conducting fibers are affected, the only medium and slow conducting fibers are preserved, so the conduction velocity may be low in such situations. What is more important is look at the tibial potential, but they've got a good amplitude. But their FAV is also prolonged. Their distal latency is normal. Conduction velocity is also relatively normal. But their FAV is prolonged. That shows there's a proximal block is there. You take the right ulnar, for example. Distal latency is normal, amplitude is normal, conduction velocity is normal, but the FAV is prolonged. Right ulnar you take is prolonged, 32.8 per 0.2. This indicates that there may be distal involvement may be there, but more importantly, there is a demyelinating block in the proximal part of the nerves. So what will you like to do?
Yes, sir.
Yes, sir.
So thickening of the, not gross thickening, but bilateral thickening of the nerve roots further, but not very gross, mild thickening. Very difficult to say when there is symmetry. But in the axial cut, you can see the thing on the nerve there. CSF no shells, protein was mildly elevated, 60 milligram per deciliter. And patient was given IVM with after giving IV patient discharged yesterday. Mild improvement after IVM, not significant improvement. It was asked to come for follow-up after microventilate. Okay, any questions? So it's actually not, it's a motor CADP.
So how to differentiate from
MMCV?
Yes, sir. How to differentiate by
It's
NCS?
what is it is perfectly correct. It will be difficult. In MMCB, there is classically conduction block should be there. Conduction block. But here it's a demyelinating type of motor CADP. MMCB called with what conduction block with relatively normal velocity.
But the conduction block can be proximal, no, sir?
It can be proximal, correct? It can be proximal. That's why there can be delay there. But when you find that if you know conduction block in the periphery, only conduction block proximally, the only abnormality will be FA. Again, there can be an absent FA. Here, only patchy conduction block, you can't differentiate. I don't know whether I made it clear or not. Suppose imagine that there is a proximal partial conduction block. The other part of the nerves will be transmitting normally. You get a normal FA. Okay. If you argue that that partial conduction block is there responsible for that is evidence of, why can't be that an evidence of MMCB possible?
Yes, sir.
Okay. But without any conduction block demonstrable anywhere, we are a little hesitant to call it as a multiple conduction block. Because a proximal demyelination also can be the same thing. And you find a peripheral demyelination also. So in that case, more proximal demyelination is there that can produce unaffected nerves are also. Peripherally unaffected nerves are affected proximally by demyelination. So it becomes a CADP-like pattern. That is an AADP Guillain-Barré syndrome and also FAV is the first one to be affected. Prolonged FA. Peripheral conduction may be normal. Okay, shall we close? Any more questions? Okay.
No, sir. We can close. Thank you.
Okay, good night. See you next week.
Good night, sir.
Good night.
Next week.